while he's getting ready, I can definitely confirm that Pavel doesn't sleep. He's on LinkedIn all the time. Take it from me. And it's fantastic that Pavel and Health Samurai and the team have put this up, so I'm really happy that we have an opportunity to connect. And I'm hoping that we can have, I'm from Orange County, that we can have similar gatherings down in Orange County, and then we have folks from San Diego out here. Hopefully we'll have similar sessions down there. The idea is to connect across Southern California. All right, good evening. I'm Gora Datta. I'm your first speaker to get this thing started. I'm the one to warm up the crowd before the actual experts come and talk. All right, so that's my role, to set the stage up for some awesome speakers who will be following me. And it is definitely my privilege and honor to give you a quick introduction to Fhir, but before I even get to Fhir, I want to give you a sense of state of mobile health, where we are, and then obviously Fhir on top of that. The page really lists some of the hats I wear. In short, I spend quite a bit of my time in working in the standards community, healthcare, being the space. HL7 is one of the key primary standards organization. I'm an HL7 ambassador. I'm also the founding chair of the HL7 Mobile Health Work Group and a few other activities within HL7. Besides HL7, I also dabble with the International Standards Organization on Health Informatics, ISO TC215. I'm one of the US delegate. In fact, Todd Cooper is the head of delegation for TC215. I also work in IEEE Standards Association and a few other activities within the IEEE space. Well, what I'm really proud of and what I do during my day job is we are the Chief Health Information Technology Officer to US physician practices, specializing in small to medium-sized physician practices in this country, basically Southern California. In my opinion, that's where the rubber meets the road, that's where healthcare is delivered. When we fall ill, we don't go to the hospital. We go to our neighborhood doctor, whoever that may be. And most of them are small to medium-sized providers. Just to give you a number, we're talking about 600 to 700,000 physician practices in this country, as opposed to 5,000 hospitals. So just to give you a sense. So anyway, so it's really fantastic for me as somebody who spends quite a bit of time in the standards community along with many other people out here. And what I say, this is where in the ivory towers of standards making we come up with ideas. But it's really great to see how exactly healthcare is working or not, and especially the standards we are developing where the healthcare is delivered. So it's absolutely fantastic. Even though I'm an HL7 ambassador and HIMSS and IEEE and many other hats, anything I'm going to say a lot. It's my opinion. And definitely I'm going to reference many companies, their products, it's all theirs. None of the trademark is mine, so I just want to get that out of the way. And so let's take a closer look. Before we even get to Fhir, I want to set the stage up from where we are as a society in terms of healthcare, where we are going and what's going on. It's really important to understand we are going through a seismic change in the healthcare access and delivery. And what's causing this change is the space of mobile health. But before I even go there, what's causing it? It is really what I call the quantified self, which is the young generation. Whether we are wearing our Fitbits of the world, whether we are wearing our wearables, medical devices, to the elderly aging population, the entire spectrum and the access to health and delivery of health is really based on mobile health. And the mobile health is really at the center of the evolution and the change which we are going through. And there are a lot of discussion which goes on. So exactly what is mobile health? And really want to make everybody understand mobile health is not just your mobile device having a health app. It covers the entire gamut of a physician who's maybe moving from hospital to his practice to a long-term care. It's your patient empowerment. It is us, patients. Remember, when we fall ill, we are not only taking the medicines which have been prescribed by our doctors, we also have our herbal meds, we also have our alternate medicine. So there are all kinds of medicines and other alternatives we take care of. And how are we keeping that information with us? It's something which was never done before. Mobile health is really making a step towards bringing it all that together. Whether you're doing an independent living or your behavioral health, messaging, public health, the entire gamut today is seeing an evolution as far as healthcare access and delivery, and mobile health is in the center of that. This is what is fueling this. For the last 10 years, so this graphics is not visible from the back, it really lays out how many cell phones we have sold over the last 10 years. We started with a measly about 100 million entire world. Today we have over 1.5 billion cell phones, new cell phones being sold every year for the last 3 years. We have sort of plateaued out. So that's a large number of devices over the last 10 years. Before 2007, mobile health just wasn't there. Mobile devices were hardly there, cell phones were hardly there. Even though I recall as part of my business and day job, we were developing healthcare apps in the year 2000, except that we didn't call it apps then, we called it application. It's only in 2007, around the global financial crisis, there was another event which took place, which really, what I call, which kicked the door open in the mobility space, which is where Apple came in, and with their iPods and the iPhones. So Apple really didn't invent mobile health and mobile computing, they kicked the door open. And then, as they say, rest is history. But what is interesting is if you think 1.5 billion devices being sold every year, if that's wow, then your jaws will drop. Now we are from millions, we are into billions. This is the IoT space. The projection is by 2025, we will have 75 billion IoT devices all over the globe. So this is a large number of devices which are coming up. So we're going through literally a seismic change, not only from a technology perspective, we're also going through an interesting change from the payment delivery system. How do we pay for services? So it's a very interesting change coming in from both sides, from the business side and from the technology side. And that's why I use this phrase, and especially in California, when I use this, people don't blink. In other parts of the country they do, which is we are going through a seismic change. And so this is really helping mobile health to take off. And yes, it's a young customers. I don't see as many young customers here or young folks here, but look at your kids, look at your grandkids. You know exactly what I'm talking about. This is what I call the iPad kids or iPad generation, where they're sitting next to each other, they're texting and not talking. But what is interesting is mobile health apps have just now started leveraging some of the features which are unique to the mobile device. We all are carrying a mobile device. I've been giving these talks for the last many years. About 5 years ago, when I would give this talk and I will ask how many of you have cell phones, not 100% of the hands would go up. Today, 100% goes up. But what is fascinating is when I ask this question, I ask a different question when I'm not in the US. In the US, I ask, okay, how many of you have cell phones? All hands go up. Outside the US, I ask, how many of you have 3 or more cell phones? 2 or more. And almost every hand goes up.
Yeah.
It's very interesting, right?
2 phones.
There you go. So it's really important to understand that these devices we are carrying, we have hardly started scratching the power it has in terms of its location services, instant messaging, biometrics, pictures, gyroscope, I mean, you name it, payment services. Almost all the solutions we have today are state-of-the-art 1980s. We are hardly scratching, and this is what I am expecting many of you are involved in, and this is really going to change how we access information, how we deliver information. Our basic whole idea about the form factor, entry, now you're going to have variables. So our expectation, okay, this is a device, and this is a laptop, desktop, no, all is going to a complete change. And how is that getting integrated is very fascinating. This is the app-centric world where we have, app, whether you are wearing a wearable, tracking sensors, medical devices. I presume this is a pointer, right? Anyway, medical devices, health record, health data via API. So this is the clue for the Fhir discussion, which will come up very shortly. But this is really the app-centric world we are all moving into. How we are using our device to connect, to access, to deliver information, health information. Actually, any information, health is what we are talking about here today. And health space itself, the app space is changing. 5 years ago, the only health app you had on your phone was the fitness app. And now we have the other apps. So what you have in the gray, the lighter ones are what was there before, and this is what people are saying. Okay, they want to have the weight app, the diet app, the sleep app, the blood pressure, and so on and so on. Why? Because people want to take charge of their health. This is the new generation we are in. We are no longer what I call our parents' generation, where we went to the doctor, they told us what to do, and we kept quiet and walked out. Today, to quote my good friend who's my GP, says, Gora, before I even can complete my sentence, my patients have the phone out and they're Googling what I'm telling them. And they're questioning me. So I better be on top of my game. Because I no longer can tell them and they'll walk away without asking a question. So it's a really very interesting change we are going through because of the technology. All right, so this has created apps galore. We have apps all over. So how many apps we have? So I started tracking this for the last 5 years, about 2015, 16 time frame. In fact, earlier on, we had about 75,000 apps globally across all the platforms, the 3 major platforms, Android, iOS, and come on, what's the third one?
Windows.
Windows. There you go. Oh, yeah. So that's so true. Yeah.
Yeah, that was my question.
No, in fact, they are really rapidly filling the gap. Look at the rise. Okay, 150,000. Next year we had 165,000. I said, all right, that's fantastic. This just blew me off. 100% jump. Last year was 325,000 apps. So I said, okay, fine. No, come on, guys, this is enough. No. Beginning of this year, nearly 500,000 apps. So I will not be surprised in the next few years we are reaching somewhere 1 million apps. Just health apps. This is not apps. This is health apps globally across all platforms. Now you can say, Gora, how many of those are real apps? I would agree. 90% really don't work. Nobody buys. But still, think about it. 10% of 500,000, that's still a lot of apps, 50,000 apps or more. All right, so how do you manage this lawlessness which is going on in the app space? Because today you have apps, you have no idea who developed those apps. Which country, which actor, what information they're doing with your information. Are they selling it? Are they changing it? I had a very interesting conversation with General Petraeus a few months ago. I'm the IEEE CyberSecurity chair for Southern California. As a part of that, I was having a discussion with the general. And I said, we were discussing about the future of warfare. And one of the discussion was, I said, the whole concept of Geneva Convention will change because we no longer have hospital as a safe zone. But that's where the warfare of the future will be fought, because you just have to change the health data of your soldiers or your generals and then see what the havoc that creates. So Geneva Convention says, no, you can't touch the hospitals. Well, that's where the future is going to be fought. So it's interesting to see how health apps have come up. At the same time, we have absolutely no reliability about the validity of the health app and the data which they carry. Many of you get health apps, we enter and then we don't like it, we want to get rid of it, delete it. What is your certainty that when you delete an health app, all your data has also gone away? It's zero. It's not happening. So you got to be careful. How do we rein in the Wild West? So that's how HL7 stepped in, that's how the mobile group, the group I'm involved with, stepped in, and we have come up with a standard called CMAF. It's a mouthful, but Consumer Mobile Health Application Functional Framework. This is the standard, it's an STU, STU basically means in HL7's term is, it's a standard but it's trial use. So which means it has a basic set of norms and guidance, but at the same time expected to change, but it is out in the field to people start looking at it and using it. And what the standard is doing is, it is basically bringing in a guidance to the app developer community, okay, how are you storing that information? What are you doing with that information? In fact, this may not be as visible, but this is where it is. What kind of authorization you have, what's the risk assessment, data exchange, data portability, usability, access. In fact, we go through the entire life cycle of a health app, right from the product information to the launch and eventually to the app removal. So it's really a guidance to the app developer and providing a framework so that we can then develop a conformance and a certification criteria on top of that. So those of you who are developing apps, health apps, start looking at CMAP. By the way, HL7 standards are all free. So if you're a member, it's available to you. If you're not a member, I think it's still available to you.
If you're a friend of Gora, is that?
It's absolutely available to you. And when we developed CMAP, we definitely looked at and took inspiration from not only what's going on in the US and the various agencies within the US in the mobile health space, we actually looked across for a change. What else the rest of the world is doing. And we found out a lot. We were not the only one thinking about this. In fact, the Europeans and the different countries in Europe have done a remarkable job in the whole health space. All of you have heard about the data privacy and the GDPR, General Data Protection Regulation. So not only that, but the different countries have done a phenomenal job of coming up with guidance on the mobile health app space. So we took all those inspiration and CMAP but thus far. All right, so now that really sets the stage up about Fhir. Remember we had that API slide, how do we connect, and Paul already talked about. So let's do a little bit of a dive. Somebody was asking earlier in the say, okay, how old is HL7 and what the name of it? Yes, as Paul said, Fhir came around in 2011. And what's the name? FHIR, Fast Healthcare Interoperability Resource, was a name which was coined by just a few of us way back in the marketing committee of HL7 in 2011. What is interesting is when we came up about that name, that was not the first name it was. I don't know whether Todd you remember or no. The initial internal name for Fhir was R for H, Resources for Health, the number 4. Luckily, WHO already had that acronym, so that name was rejected and there were a few others we had to choose from. And we chose Fhir thinking that, that makes sense. In fact, the early version had an E for enterprise at the end, and we said, no. It really doesn't do any add value. So Fhir is the name we are stuck with, and this is what is taking the world by storm. All right, before we even get to Fhir, for those of you, the 50%, who want to know what is HL7 all about, what is standard, so this is my oversimplified slide of what HL7 is all about. By the way, you won't see this kind of abstraction at the HL7 website. And that's why this is my opinion. So yes, as an organization, HL7 was formed in 1987. In fact, we have one of the early members, Abdul Malik, here with us. Abdul Malik, since when?
91.
91, there you go. So if you have any questions about HL7 from early days, he's the man. But in terms of standards, as a standards organization, I categorized 4 different types of standards. In early days, 1987, 1998, early days, 2 computers in a hospital, how do you communicate when they're connected? Messaging. What exactly is messaging? Think of a train. Different compartments in a certain sequence, information is flowing across the wire. That's what is messaging all about. And the early versions have several names, it's called version 2. Yes, there was a version 1. And then what we have is a version 2, and there are different flavors, but it's really version 2. And then somewhere, but then that created, and give a quick summary, we had different flavors of versions and different flavors of version 2 itself, and there were all kinds of duplicates and confusion which created. And therefore, something called version 3 was born out from there. So this is all in the messaging space. I'm really oversimplifying it. Those of you who know what I'm talking about, so close your ears. From messaging, we came to the document. Because as humans, as in the healthcare, we don't deal with messages, we deal with documents. And especially the healthcare, whether you're talking about a prescription, you're talking about a discharge summary, whatever you're talking about, if you think about in the healthcare paradigm, you're dealing with documents. So how do you capture, how do you come up with a document architecture standard? That's what the document CDA is all about. The next evolution was functional model. That is, if you think of an electronic health record system as a black box, what are the behavior and the characteristics of that particular black box needs to be? So that's how the functional model is all about, is providing you with the specification of the black box. Think of a car. When I tell you I got a sedan, a 4-door sedan, you exactly have an idea of what I'm talking about. So that's where the functional model is all about, trying to give you a sense of what are the functions and the criteria of a particular system. And then comes the year 2000 and beyond, we moved into the service-oriented architecture, and that's where Fhir is a part of that. And so this, as I said, very oversimplification. And then there's some more. There's something called RIM, the reference information model. And again, I will point to the expert at the back of the room. Abdul Malik is one of the early authors of the reference information model. And there are data types, vocabularies, and terminologies. So this is your complete 101 few minutes of what HL7 is all about. All right. With that confusion about in 2011, Graham Greene said, okay, we need to do a better job of coming up with interoperability of exchanging information between any sources. And how do we do that? So therefore, Fhir was born. Fhir, just as an in case anybody asks you, is Fhir an API? And the answer is no. It's Fhir is a specification which describes a set of resources, frameworks, and APIs. So it's not just an API. All right, so what is an API? Let's do another homework. This is getting a little deep into it, but it's interesting to note Fhir is based on what we call a RESTful API, a REST, a representational state transfer. It's nothing but cell phones, mobile devices, your client machines, talking to HTTP. This is what you do when you go to a browser. You go to a web server, it gets the information back to you. That's what this is all about. And guess when was this born? This was born in the year 2000. This was a PhD thesis of Roy Fielding of UCI. Brian, make a note of that. Brian is my colleague, and we both are based out of Irvine. And University of California at Irvine is where Roy Fielding did his PhD dissertation. So this as new. So Fhir is based on RESTful API. RESTful API was defined by Roy in the year 2000. This hyperlink gives a complete his PhD dissertation. It's fantastic read. If you're having difficulty falling asleep in the night, click on this hyperlink. Magic. It's a fascinating dissertation. So this is where, when we talk about Fhir, when we talk about interconnectivity, because it's not something new, what Fhir is trying to do. This is what V2 was trying to do. This is what V3 was trying to do. This is what CEA was trying to do. What Fhir is trying to do is the new world we live in the world of web and web services, and how do we exchange that information seamlessly between the server and the client machine which you have. All right, let's peel the onion a little more about Fhir. Fhir follows what's called the 80-20 rule. That is, it doesn't try to solve everything for everybody. It's trying to solve for 80% of the time. And those 20%, okay, we'll handle that separately. So it's not the answer for everything, and what it doesn't have, you'll have to go and add those extensions. It is also goes through a certain. You hear things like normative standard. A normative standard is something which is once published will work in the future as well. Interestingly, HL7 has decided that an STU, which is one level below a normative standard, is not necessarily forward compatible. So if you are dealing with an STU version and you're implementing an STU, then be aware that some of the features may break when the normative version comes in. But what is interesting is Fhir takes a little different stand in terms of the maturity models of its resources. And I'll touch upon that soon. It's not that you have something DSTU, STUs, and then it goes to normative. No, it goes through a level of maturity. So level 1 through 5, and 5 being the highest. So when you start reading the Fhir specs, start looking at the maturity level of the particular artifact, and then you see progress from 1, 2, 3, 4, 5. All right. So right now we are at what's called an R4, which is the first normative standard. And the way it is, it means a majority of the resources and artifacts are normative, doesn't mean all of them. And the HL7 specs, the Fhir specs very clearly tells you which are normative and which are not. And the earlier ones are R3, R2, R1. And the team is now working on R5. So that is the state we are. All right. Fhir resources. We'll hear more about from the next speakers, but this is just to set you the stage up. There are 5 different categories. You've got the foundational one, you've got the base class, base resources, then you've got the clinical ones, and then we have financial and the specialized. So these are the, just at a glance, sense of resources. What do we mean by resources? Patients, organizations, devices, just to give you a sense. It is any artifact, any atomic unit. So think of these are your Lego blocks. So different Lego blocks with different properties. How do you connect these Lego blocks and then create a bigger thing out of that? So that's what is Fhir about. This is the value of Fhir. Why Fhir is really taking off is the simplicity and the flexibility. It hides the complexity behind it. So don't be fooled by saying, oh, it's something simple and easy. It's not. It's the simplicity is how it is presented to you. But then if you are really working with Fhir and start developing solutions, then you have to know a little bit about the data type, data structure, the RAM, the V3, and so on and so forth. All right, so where do you go? 2 things. One is, a lot of people get confused. There are 2 websites. If you want to know technical details about Fhir, you go to the HL7 website, hl7.org/Fhir, FHIR. But if you go to www.fhir.org, that's the Fhir Foundation website, and that is for the Fhir implementers. This website is still work in progress, and Todd is one of the board members of the Fhir Foundation. So if you have questions about where this is going, but at this stage, Fhir Foundation website is at a very still early stage. Having said that, you will find some very interesting links out here. So yes, definitely look at it. But if you want to have technical details and learn about Fhir specification, go to the hl7.org/Fhir website. Who's using Fhir? Maybe you recognize some of these names. Either they're using Fhir or they built that into their specification. This is a big deal. So it's no longer something geeky, it is no longer something, yeah, maybe not. No. It's here to stay. And those of you who's asking question, what's after Fhir? Okay, ask me after 25 years. This is the beginning of the change we are going through interoperability, and hopefully, as I tell my kids, it'll keep me busy for a few more years. All right, so as a society, as we transition from a digital framework, mobile use is becoming ubiquitous. How we access information, how we disseminate information, it's only a tap, swipe, or a transmit away. And this is the vision of the future for me, is life in the 21st century. A standards, Fhir-enabled, cloud-connected, IoT-driven, microservices-enhanced, cyber-safe digital health world. Thank you.
Pretty much exactly.
There you go.
Okay, Gora. So, how many people know what Fhir is now? Very good. So our second speaker, and then we will have a break, is Dr. Aziz Bakswala. He will speak about one of the most popular use cases of Fhir, how you can supplement electronic health record systems such